as far as we were looking at things like our preload, our afterload, things like that. So what do you want to look for when we talk about this? Well, some of the signs and symptoms, just to quickly go over, give you an idea, okay, on each individual area. Now, cardiogenic, you'll get those distended neck veins at JVD because you have that increased jugular pressure going on, weak or an absent pulses. You might have, again, those arrhythmias. Most often it's gonna be tachycardic, and you might get that pulsus paradoxus in cases of things like cardiac tamponade. Now, in hypovolemic type shock, again, this is that direct loss of that effective circulatory blood volume, either due to blood loss or due to that vomiting and diarrhea. You'll have the rapid, weak, thready pulse due to that decreased blood flow combined with that tachycardia. You get patients that'll have cool, clammy skin because they have that vasoconstriction and that stimulation of vasoconstriction going on, rapid shallow respirations because of the sympathetic nervous system, and even also because of acidosis, thirst and dry mouth, which of course pediatrics, you might not actually get them complaining of that, but that is another thing with hypovolemic type shock. And then you get that cold and mottled skin, and especially you're going to see that in extremities of the patient because they've got the insufficient perfusion of the skin. Okay. Now, in distributive type of a shock, again, that includes things like your septic shock, and this is where you're having the fever, and that's where the skin might not be cool and clammy like you might see in other forms of shock, but it'll be more warm and sweaty due to the vasodilation rather than the vasoconstriction. Anaphylaxis, another form of distributive shock, you don't keep in mind. You might see those hives, you might see that localized swelling, that edema, especially around the face, and things like that, and you're going to have that weak, rapid pulse, and then keep an eye out for breathing issues. Okay, anaphylaxis, you can get that breathlessness going on because of that narrowing of the airways and swelling of the patient's airway. All right, so when we talk about evaluating shock in pediatrics, real quick, again, this is about staying ahead of the curve, guys, right? So, you, of course, regardless of what's going on, whether it's hypovolemic, cardiogenic, whatever, keep in mind, use your ABCs. Assess the patient's airway, their ventilation, and then go into your circulatory system. Check the patient's respiratory performance, their rate, the pattern, how often they're breathing. Are they having a difficult time breathing? Look at their skin color. Is it cyanotic? Is it flushed? Is it pale? If you have O2 saturation capabilities, check that as well. And check the patient's level of consciousness, which can help you discern if the respiratory pattern, the respiratory rate is sufficient enough for them, okay? You know, altered mental status is one of the first things you're going to start seeing when they're not getting enough oxygen. And of course, circulation, their heart rate, the blood pressure, are they perfusing it? Are they cool, pale, diaphoretic, capillary refill? And of course, check pulses. Distal pulses are important, to figure out what might be going on with the patient. Now, a little bit more on evaluation. Think about the early signs of shock when it comes to pediatric patients, okay? Sinus tachycardia, that delayed capillary refill, and you get the baby or the child might be fussy, appear irritable to you. This is their mental status changes going on, okay? Now, your late signs of shock, you're going to have that bradycardia. The mental status is going to further deteriorate, where they're going to become lethargic, maybe even be unresponsive. You might have that Cheyne-Stokes breathing going on as well. And hypotension in pediatrics is a very late sign in shock, and you don't want to get to that point. So this is why I'm trying to point out some of these key points here to try to keep you ahead of the curve so you don't get to the point of that lethargy, that unresponsiveness, or that severe hypotension that becomes a very late sign for the pediatric patient. The lower limit of the systolic blood pressure normally in pediatric patients is usually 70 plus 2 times that patient's age in years. Now finally, look at the cardiovascular assessment for pediatric patients.